All right. Good morning, good afternoon, and good evening to everyone. Thank you for joining us at this ISCA webinar. My name is Dr. Jeff Donaldson. I am the convening host for this webinar for the International Social Capital Association. The association's mission is to advance the research and application of the social capital concept, and the association is welcoming new members. Today, we have the privilege of Dr. Hwang, who is an assistant professor in the Department of Sociology at Ajou University in South Korea. He received a PhD in sociology and an MPA from Texas A&M University. His academic interests include organization theory, environmental sociology, community resilience, philanthropic studies, and social entrepreneurship. His research has an overarching theme of identifying how organizations respond to institutional heterogeneity, grand societal challenges, and challenges to organizational sustainability. And I just ask that throughout the presentation, you keep your microphones on mute and listen
Mhm.
intently. Dr. Hwang, it's over to you.
Thank you very much. I'm going to share my screen here. Can you see my screen in full? Okay. Uh, Thank you very much for inviting me to this privileges the presentation. I'm going to talk about the unveiling health inequities between Hispanic and white people, exploring the role of the social capital and public trust. Before jumping into the my research, I have to briefly talk about my co-authors. This paper was published in the Social Science Quarterly last year, and we started this research in 2021 when I worked at the Texas A&M University as a assistant research scientist. And my co-author, Kate Anderson, she's at the University of Houston. I used to work at the University of Houston by this February, and I moved to the South Korea, which is my home country. And Dr. Bedlitz at the Texas A&M University, who was my former boss when I was doing my postdoc, and Dr. Bixler at the LBJ School at UT Austin. And this research was funded by multiple institutions, including RGK and the Michael Dell Foundation and Texas A&M and UT Austin. And this research was approved by the IRB at the University of Texas. So I'm going to go through the introduction, literature review, and brief explanation about our method and findings and discussion. First of all, the racial disparities in healthcare services between Hispanic and white population, which has been the chronicle and the persistent social problem in the United States with the increase of Hispanic populations. And this disparity is more pronounced among the low-income Hispanics who frequently have limited access to the healthcare coverage and services. So lack of access to preventive care among Hispanics, among which leads to the higher incidence of certain chronic disease. And this figure shows the uninsured rate by race and ethnicity in the United States. As you can see, Latino and Hispanic population is the largest number of uninsured rate. And average total uninsured rate is 9% in the United States. White and Asian people, they have a lower uninsured rate, but the Black and Hispanic, they have a higher than average. The Hispanic population, they have a far higher than average of the uninsured rate because they have a large portion of the immigrants and the undocumented population. And why we study in Texas? Texas is the highest rate of uninsured population. When you see the map here, you can see some counties who have that have a higher rates of the uninsured population than average here, but Texas is darker than any other states. So Texas is the highest uninsured rate state. So in the average of the United States, Texas has a higher uninsured rate for the white and Hispanic, but when you see the Hispanic population is far higher. In Travis County, which is the home county of the Austin area, which is far higher than Texas average and lower white people. But still, this is uninsured rates from our survey data. The 30% of the Hispanic population and more than 15% of the white population, and Black population is far higher than the United States as well. So the racial disparities to the healthcare access for the healthcare coverage and the services is a significant problem, social problem in the United States. We listed some causes of the racial disparities in healthcare coverage. First of all, which is the income disparities. However, healthcare access disparity between Hispanic whites persist even when income levels are considered. Also, the other socioeconomic indicators, including the education and occupation, can explain the racial disparity in access to healthcare coverage. Income, education, and occupation, they are all related. So in this complex, the relationship among the income, occupation, and education, well, this study posits that the limited social capital among the Hispanic population can hinder their ability to have access to information and quality of healthcare services. This our research question is what is the role of social capital to improve healthcare access for the Hispanic populations, and what can the former institutions such as the government agencies and nonprofit organizations can do to enhance the social capital among the Hispanic populations? To do so, we public needs to have a trust in the former institutions, and there should be higher levels of the public trust and former institutions. So we are examining the moderating role of the public trust in the former institutions between the relationship between the Hispanics and the access to the healthcare services. So overall, this study examines how access to the healthcare service and social capital differ between the Hispanic and white when controlling for the socioeconomic characteristics, including the income, education, and occupation. And how does the social capital mediate the relationship between the ethnicity and the access to the healthcare? And how does the trust in the nonprofits and government agencies moderate the role of the social capital in access to healthcare services? So this is diagram summarizing our research question. Independent variable is the racial identity of respondents of being Hispanics, relationship with access to healthcare services. In this primary relationship, we are examining how does the social capital mediate the relationship, and then moderating role of the trust in the former institution, such as public and nonprofit sector. So we are jumping into the literature review and hypothesis. Racial disparities in healthcare access. The CDC shows that the data, there are similar life expectancy between Hispanic and non-Hispanic whites. This is male and this is a female. Female live longer than male. So the Hispanic and white, they have a very similar life expectancy. Even the Hispanic have live longer than white people here. However, Hispanic experience the disparities across the several key health metrics. including the overall general health, separated health, and other chronic disease, including the diabetes, obesity, the several infectious disease. Also, the Hispanic have the lowest rate of the healthcare coverage among the racial and ethnic group in the United States, but less likely utilize their healthcare services, particularly preventive healthcare services, such as annual physical and routine screening and immunization. That is the social problem. Literature provides the two explanations: socioeconomic status and workplace conditions, which is the education and occupation and income. Hispanics are often employed in workplace that do not provide the healthcare coverage. Due to their low socioeconomic standing, on average, may have a harder time affording the Medicare. And also, there are some structural barriers, including immigration factors, language skill, time spent in the United States, and citizenship status. These factors can contribute to the lack of coverage and poor healthcare utilization among Hispanics. From our data, this is a result of our preliminary research. I compared the accessibility to the healthcare between white and other racial minority when controlling for the income. Income is completely controlled in this analysis. However, there is a gap between white and minority people, minority respondents, for the access to the healthcare services. So from this preliminary analysis, we posit that there should be some reason, such as a social capital, can play a role, the widening the gap of the healthcare services between Hispanic and white populations. So structural barriers, including healthcare, language skill, and culturalization, limit the job opportunity and prevent some Hispanic immigrants from seeking type of employment that provide the healthcare coverage and social capital in society. Also, 34% of the Hispanics are foreign-born in 2017, and the literature suggests that English-speaking Hispanics in the United States have a rate of healthcare utilization that are more similar to those of whites. So we pick the social capital is a cause that can limit the healthcare access to the healthcare services for the Hispanic population. So social capital can represent the flow of individual networks, trust, and interactions with others that can result in economic benefit and return as well. Social capital is defined as a tangible as well as intangible resources that can be transferred to the economic and social capital, such as maintenance of social norms and stock of trust, availability of social networks to the individual or social group. So with the social capital, individual can accumulate their information, quality of information and trust, and they can access to the greater information as a return. So social capital in return creates the cohesive community with the high levels of trust and reciprocity among the community members who share the similar norms and beliefs and values. So creating a robust social capital in communities can increase the access to the healthcare, as research reveals that more social capital is likely to be associated with better health outcomes. This is a comparison of income, social capital, and access to healthcare from our research. Between rural and white areas. So overall, the Hispanic and Latinos, they have a lower income the social capital and healthcare, access to the healthcare compared to the white population. In this complex relationship amongst the income, social capital, and access to healthcare, we hypothesize the levels of social capital can be positively associated with access to the healthcare coverage. Also, social capital will positively mediate the relationship between the being Hispanics and access to healthcare coverage. In addition, we were trying to find the moderating role of the public trust, because if people have a higher levels of the trust in the former institutions, they are more likely to participate in the co-production of the public services and the city hall meetings and the policy implementation of the healthcare services. So access to the healthcare is a challenge for the many Hispanics due to various barriers, such as a lack of insurance, ineligibility for the public assistance program, high cost of the healthcare services. Also, a lot of people have a lack of transportation, social discrimination for the immigrants, and language barrier compared to whites. These racial disparities in healthcare access for the Hispanic can be reduced by effective policy implementation. But cross-sector collaboration is needed to eliminate the systemic risk factors that increase the barriers to the healthcare for Hispanics. That's why institutional assistance from the nonprofits and government agency is highly needed to help vulnerable population and racial minority to remove the barriers. And community-based participatory approach have been promoted to support the collaborative efforts to improve the unequal access to the healthcare services. For the effective policy implementation to reduce this type of racial disparities, public trust in former institution is that can enhance the citizen participation in policy implementation and its effectiveness, because those former institution can get some feedback from the citizens. When perceived legitimacy and trust in the former institution implementing the health policy can diminish it, and it signifies failure to achieve the social equity in healthcare services. We all witnessed some instances during the COVID-19 pandemic. Public mistrust in the federal government was witnessed due to the misinformation and inconsistent policy implementation in the early stage, which increased the healthcare inequalities more burdensome to the racial minority groups. The other research found that there are more mortality rates among the racial minority during the COVID-19. On the other hand, equitable response to the nonprofit organizations playing a supplemental role to government agency, which was the trustworthy, which increased the perceived legitimacy for the nonprofit agencies. So our second hypothesis is a public trust in the nonprofit organization will be more likely to enhance the accessibility to healthcare services than public trust in the government agencies. Jumping into our method and findings, our study site is Austin area. As we saw in previous figures, Texas has the higher rates of the uninsured people than US average, and Travis County has the higher rates than the Texas overall. So that's why we picked the greater Austin area. Austin area has the 1 million population, and which experiences the growth of the Hispanic immigrants in the United States. So we collected data. Survey collection was completed through the external form with 1,215 respondents conducted through the phone survey, and the 25% of the total sample size was from the web-based panel procedures. So our dependent variable is coded as access to the healthcare coverage with the three questions about whether they have a private insurance and the workplace coverage and the public Medicare or Medicaid services. Our independent variable and mediating variable is a social capital, and constructing the social capital variable focusing on the bonding social capital following the Bixler's constructions. Question for these three dimensions are Likert type, and we have three dimensions about the cohesion, trust, and network. We asked almost 14 questions to construct the social capital variable following the Bixler's constructions. And our independent variable is a racial identity of being Hispanics. And in our sample, 201 reported as being Hispanic and 635 was a non-Hispanic white. We recorded this sample as a 1 for Hispanic and 0 for the white and black. This is a binary variable. Moderating variable is a trust in the former institutions. And we divided into 5 groups into two types of the former institution. First one is a government agency and nonprofits. Also, we included the control variables such as urban residency, gender, income, education, attainment, and age, political stance, life satisfaction, and flood experience and the extreme heat experience. Our analytic strategy is first of all, it's a OLS regression for the hypothesis 1A. And we employed a partial path analysis to test the mediating effects of the social capital. And we employed the moderating multiple regression to test the hypothesis 2. So mean the BIF is a 1.23, which suggests the multicollinearity was not a concern for this analysis. So this is OLS regression. For the social capital as a dependent variable, Hispanic has a lower social capital. They are negatively associated, and social capital overall, they're positively associated with the healthcare access. And this is a partial path analysis for the hypothesis 1B. The being Hispanic is negatively associated with access to the healthcare coverage. And Hispanic has a lower social capital. If they have a social capital, the possibly associated with access to the healthcare coverage. But in total effect, for the mediating effect of a social capital on the relationship between the Hispanic and access to the healthcare, through the lower social capital, which has a lower levels of the access to the healthcare coverage. So this is a result for to find the moderating effect of a former institution in the trust in the former institution. We found no significant effect of the trust in the public sector. However, we found a significant effect of trust in the nonprofit organization. For the non-Hispanic whites, trust in the nonprofit sector, it has a negatively associated with association between the social capital and the trust in the nonprofit sector and the access to healthcare. But the Hispanics, if they are higher levels of trust in the nonprofit sector, their access to the healthcare coverage increases overall. So what we found is trust in the nonprofit sector can increase in the access to the healthcare coverage for the Hispanics with the institutional assistance. So we found the hypothesis 1A and 2 is supported. However, the 1A and 1B, they were supported. However, the trust in the former institution, such as a government agency, was not supported, but the trust in the former institution, such as a nonprofit, is supported. So the results support our hypothesis social capital attenuates a negative effect of Hispanic racial identity on access to the healthcare coverage. Also, public trust in the nonprofit plays a role in enhancing the Hispanic access to the healthcare coverage. This is because the social capital among the individuals improve the social connections and facilitates a sharing of the information, which helps the individual seek to access to healthcare coverage. Especially for the Hispanic social capital is weaker than whites, which makes it more difficult for Hispanic to obtain the proper access to healthcare coverage. Institutional support from the nonprofit organizations can help Hispanics to have a better social capital. Between nonprofits and government agency, racial minority of Hispanics are more likely to have an advantage in access to the healthcare coverage from the nonprofit. This may be due to Hispanic facing more systematic and structural barriers, such as documentation preparation and language skill to engage in the public assistance program than nonprofit assistance. That's why the Hispanic have a higher levels of the uninsured rate and Black people, because they cannot enroll in the Medicare and Medicaid programs. Increasing social capital is an integral part of the building socially equitable communities, especially when facing the collective challenges such as health disparities. Providing the institutional support from nonprofit organizations and the government agency to build social capital and interact with the other community groups might lower those types of the structure and systematic barriers to accessing healthcare coverage. Lastly, the National Institute of Health recommends community-based participation to empower the vulnerable population to address these types of challenges. Nonprofit organizations, they have a high levels of trust, which can moderate the negative impact of racial identity on Hispanic and access to the healthcare coverage. Hispanic population, they are more likely to seek help from the nonprofit and community-based organization, more likely to consider racial and ethnic and cultural context. By involving the nonprofit in implementing equitable and effective health policies, cross-sector collaboration needs to be promoted in the multiple areas. Thank you very much for listening to my presentation.
Well, that's wonderful. Thank you very much. We appreciate that. We have questions. You can place it in the chat, or you can put your hand up. Either way, if you wanted me to just put it in the chat and I'll ask it for you, that's perfectly fine. Or you can put your hand up and then I'll call on you and unmute and pose your question. But while you're all thinking about your questions, just one of the last points that you brought up, Dr. Hwang, that kind of interesting is I understand the call for the institutional support to build social capital. I'm often challenged by finding the methodology.
Oh, yeah.
The call is well understood, and I totally agree with you. I haven't come across a methodology that has been successful. Have you come across a way to do this, to operationalize the idea?
In the review process, we had a lot of feedback about the operationalization of the R variable. A lot of reviewers, we don't like your measurement and the construction of social capital, as well as how can you measure the public trust in the former institution with a couple of questions. So our measurements are not perfect. However, actually in the beginning, we were trying to find out whether respondents have their experience in the citizen participation, so in the public sector or the nonprofit sector. But the actual citizen participation is very low. The very small portion of the respondent, they actually participated in the some town hall meeting and the volunteering. That's why we try to measure just the general public trust. However, this is not a perfect measurement because as we all know, there are some like a self bias. Even though they do not completely trust in the public agency, they sometimes just mark as yeah, this is a good level. And yeah, I like our nonprofit organization such as a food bank and the Habitat for Humanity, but that cannot represent the overall of the nonprofit sector. So in the future, our research team is trying to conduct the experimental research survey. So we are giving a scenario in a specific situation. Do you trust this nonprofit organization? In this scenario, are you willing to participate in some nonprofit volunteering or the citizen participation, such like that? So our survey measurement is trying to get improved through the series of the survey. Yeah, this is not perfect. Yeah.
No, but with who is perfect? Science is imperfect on its own, and that's by design. We're actually trying to start up a special interest group. We have a couple of special interest groups in the International Social Capital Association, and one is on measurement.
Oh yeah.
For those that are interested, if you're a conference person and you like traveling, in March of 2026, ISCA is hosting our first ever social capital conference in Dubai.
Okay.
At the end of March in 2026. And one of the streams is going to be measurement, because we're all, to some degree in our different fields of social capital investigation, are trying to, while it's an imperfect science, as you say, but bringing many minds together to look at all of our different methodologies to try to measure social capital. So you are very much part of the crowd where we are all searching for just a little bit better measurement tool, a little bit more accurate. And I'm a big fan of what you said about participating as a measure of trust.
Oh yeah.
Do I trust the Red Cross? Yes. Am I willing to volunteer for them? No.
That's right. Yeah.
No, but that's a clear measurement of,
yeah.
I trust the organization, but do I trust it enough to become involved to support its mission and ensure its mission's continuity? Those are two different levels. And so I find it very, very interesting. But I just wanted to say that, no, you are absolutely not alone in that measurement. And
thank you.
And we're trying to put that together. So if you can put it in your calendar for March of 2026 to come to Dubai and join us for that conference, because we're trying to bring together a couple of hundred social capital researchers and people interested in social capital to try to start a cohesive group of individuals. And what we're also interested in, for those of you who are listening who are not scholars, we're looking at practitioners as well.
Oh yeah.
So people who leverage the value of social capital in the application of their professional endeavors.
That's very important to hear from the some practitioner, because we know the theories. However, we don't know about the field level experiences. As you said, do you trust the Red Cross? Yes. Are you willing to volunteer for the Red Cross? No, because I don't have time. But are you willing to donate to the Red Cross, yes, I can donate to some money. So Bill Gates, such as Bill Gates, he cherished his time. So he does not have a lot of time to volunteer. However, he's highly willing to donate to the Red Cross. So there are some variances for the people based on their socioeconomic status and trust level too. Yeah.
And there, I have a colleague in Africa who is doing some fantastic work on tying social capital and donations.
Oh,
So they're
that's great.
looking at
Yeah.
measuring social capital through the frequency and value of donations that people make, because it's
What
another
part of
measure.
what part of Africa? I mean, it's a big, huge continent.
Oh, yeah.
I'll be,
Yeah.
yes, you are absolutely true. The gentleman is in South Africa, and he's
Thank
doing
you.
work with a colleague in Kenya.
Okay.
And what they're looking at is there are 2 or 3 donation platforms that are unique to Africa, and they're looking at the frequency of that and finding and trying to. Their hypothesis is people who donate regularly to community events have a high degree of social capital because they're tied to and care about where they live.
That's right.
So
Yeah.
as another measurement tool, we know crime statistics, we know voting, we know membership in organizations, all of
yeah.
Dr. Putman's great work on membership. But it's just to say that there are some interesting avenues people and researchers are pursuing to try to find different methodologies to better understand how we measure social capital, because I work in the disaster resilience space, and we're finding some of the evidence I'm finding is that there's an inverse relationship to economic status. So the less
Yeah.
money you have, you actually have a higher degree of resilience because of the strength of your social capital.
That's right. Yeah. Yeah.
Because if you've, like, I live in North America, I've been a few places in the world, but not many. When you go down to the park on Sunday, there are certain cultural communities that have 50, 60, or 70 members having a barbecue.
Oh, yeah.
They have a far higher degree of social capital than I do. And they will fare better in a disaster because of that social capital. They will do better than I will if I have a large amount of money and they have a large social network. Their outcomes will be better than mine.
That's right. Yeah.
It's a measurement of trust in your community and connection to your community is a more valuable asset than money in disasters. Now, I don't know whether that's generalizable across other situations, but that's one thing we're starting to realize is money gets you an escape valve, but it doesn't necessarily improve.
That's very highly generalizable because the resilience relationship between the resilience and social capital is a highly correlated and associated. When they have a higher social capital, that affects the community resilience to mobilize a collective resources to respond to the external threats such as natural disaster and pandemic too. In my research published in the City and Community, I found some relationship between the social capital and collective resource mobilization. And then I tried to challenge the Robert Putnam's argument. Robert Putnam said the social capital is high in the racially homogeneous groups, communities. However, in responding to the external the disasters, external threats, racial diversity plays a catalytic role in signifying the social capital for the resource mobilization. But I like Robert Putnam as well. Yeah.
He's a stalwart voice that's very difficult to argue with.
That's right. He came to Texas A&M University when I was a doctoral student, and we sat together. We had almost a 3 and 4 hour conversation, and he's a distinguished professor, but he sat with me with a doctoral student, but we didn't finish the conversation. So he called me at night, please come to my office tomorrow morning, and we started the conversation again. Yeah, so he's a very wonderful and a very generous guy. Yeah.
Yeah, absolutely. And I put the
Yeah.
link if anybody's interested for our conference announcement for
Oh, sure.
Dubai is in the chat there. Just if you're interested. The more detailed information will come out, and we're trying to do our best to keep the cost as low as possible because we understand travel to Dubai is not the cheapest, but it's actually probably the most central location we could find on the
Sure.
globe.
Yeah.
Because we have some support from a local university there. We have
Oh, great.
support from the Dubai Ministry of Tourism.
Oh, okay. Wow, that's great.
And so we're trying to keep it well under what other conferences may be to try to attract voices and to try to provide as well reduced admittance rates for PhD students and master students. But we also looking to see what we can do about bringing the practitioner in because we were speaking earlier, the value of the practitioner, like in your study, understanding the link to the healthcare world. How does the healthcare world view social capital in the execution of their role? And then you can tie that back to your research and say, okay, now we can cross populate here and say, hey, these relationships are really important. We just finished one in a city in Ontario here in Canada where we looked at the relationship between the business community and the government. And it was pretty much absent. They everybody wanted to help get the city ready for a disaster, but nobody was actually speaking to each other. Nobody
Oh,
had
yeah.
actually set up that enabling environment to bring the voices around the table. And so you had a business community with great assets, great intent, and the desire to help the city in times of stress, but they had no idea who to talk to.
No. They have a very great resources, but they don't know what to do with their available resources. Yeah.
Yeah, I gave a presentation at a conference in Northern Ontario earlier last month talking about the value of the whole of community. And this is a small city in a mining area surrounded by 30 major mines.
Oh, okay.
So if you think about the equipment and the capabilities that are sitting on the mining sites, is absolutely everything the city would need in a disaster is already there in their neighborhood. They just haven't built that social capital connection, built that relationship with the mining companies to say, you know, when I need heavy equipment to clear a highway after a mudslide, why am I bringing it 20 hours up the road when it's parked 4 kilometers down the road at a mine site? But I don't know it's there and we don't have that relationship. And the mining companies are happy to help. They live there. Their families live in these towns as well.
That's
Their
right.
families go to these schools. They're part of the community. But part of it, I think, and I like your relationship there between the not-for-profit and the strength and the trust capital in that, because I'm trying to work on the other side between the residents and the for-profit corporations. And that is a pretty significant gap right now in institutional trust between for-profit corporations and community organizations when both looking at the same. So I think it's a very interesting opportunity. If anybody has any question, there's only a couple of us here. Feel free to unmute yourself and jump right into the conversation. We'll hang around for a little bit longer, and then in about 15 minutes we'll close it down. But feel free to jump right in. This is an open conversation. If not, I did have one other question I wanted to ask about it. It's my last one that I had written down here. Are you aware of, or has there been much research into the value of the not-for-profit delivering the healthcare and not just making the connection?
I noticed that there are many for-profit healthcare services, such as the including insurance company. However, I didn't explore much about that. So, but what when I worked in the University of Houston, I had one police graduate student working in the Houston Department of Houston Police, HPD. And have you guys heard about the HCA hospitals?
No.
HCA hospital, which is the largest for-profit hospital in the United States and owned by hedge fund. And so that's a for-profit hospital. The 85 or 80% of the hospitals in the United States is nonprofit. Surprise, surprise. But the HCA is a absolutely for-profit hospital. But what my students, a former student who worked at the Houston Police Department said, they do not tend to bring the patients to the HCA hospital because the HCA hospital, they care so much about the cost. They do not want to spend a lot of things on the patients, like emergency patients. So the mortality rate and the HCA hospital is higher than any other nonprofit hospital. So a for-profit hospital, for-profit insurance, they care so much about the cost and efficiency, which decreases the social capital. That's what I observed so far. Yeah.
That's interesting. We do have one question there. Do you want to unmute yourself, or you want me to ask it for you? Okay. Is social capital needed to progress financially?
According to Robert Putnam, the social capital needs to be transferred to the economic and social benefits, which can be economic benefits or social benefit. That's types of social capital. I don't think social capital is the need to progress financially. However, the emotional benefit and the social benefit can transfer to the financial benefit as well. If I feel better, I cannot buy it with the money. So anyway, it's a benefit for the people on social capital, improve the benefit. Yeah.
And I'll, if you don't mind, I'll add to my view of that is social capital is by definition the glue and the lubricant that holds society together. So the glue that holds us all together in whatever bonding or bridging or type of groups that we find ourselves in. What I find in my research indicates is that social capital improves the flow of financial assets, as well as human capital, which we can consider skills, knowledge, and training, financial capital, which is money itself, and then physical capital, the physical goods around. Strong social networks allow the flow of that better. If I don't know you and you show up at my door and ask to borrow my lawnmower, the odds of it is going to be pretty close to zero. But if you're my neighbor 4 doors down that I wave at, I see all the time, I might know you by first name, we chat at the mailbox, that existing social capital is going to allow the flow of that physical good, the lawnmower, to happen. Money works the same way. In my research, what I found is that strong social capital gives you access to more financial resources by the nature of having strong relationships. Because with norms and trust of reciprocity, it's not never a guarantee, but I posit that you'll have a higher likelihood of getting access to money.
And valuable information too. Yeah.
And valuable information. And there's a follow-up question there. When social capital isn't obtainable for someone, what is the likelihood of that person to experience homelessness, crisis, or other problems?
What does it mean when social capital isn't obtainable for someone who is the likely of this person?
Somebody generally has weak ties. When somebody has
weak ties,
social capital, weak ties, is that an increased likelihood for crisis?
Yep. Not that kind of extreme crisis being homelessness. And however, the more probability, because if I do not have the social capital in the conference, or professional networks, I would have a more harder time to get a new job. If I have high levels of social capital, I can easily to get a new job in with better salary, higher salaries, and the better the benefits as well. The Jeff, you might already notice that the in the academic networks, people who have higher levels of social capital, who highly engage in the conferences and the professional networks, they can get a better job where they move around in the universities. So it applies for the industries and the professional as well. Yeah, I think so. Yeah, but not that kind of the extreme experience like a homelessness. Yeah.
We had a presenter about a month ago, and any of our previous presentations, for those who are listening, are all available on our YouTube channel. This recording as well will be up and available on YouTube to look at. We had a presenter to come in to talk about whether social capital is influential in getting a job or getting a promotion within a job. Does your knowledge, it's the old adage, it's who you know to get in the front door. And they actually did a pretty decent study to examine, and then, whether you agree or not with their conclusions, it's all over on YouTube. I won't spoil it for it. But when it comes to weak ties, I do believe, and I've done not a great deal of work, but I have done some work with marginalized and vulnerable populations, and during the pandemic, and those that had weak ties did worse. I didn't have enough data to run any correlations or any data analysis on it, but my intuition told me that those with weak ties, those people who were already in precarious positions, prior to the pandemic hitting and had weak social ties, did not do well.
That's right.
Had worse outcomes. They actually came out of the pandemic at a lower socioeconomic level than they entered. Now, I can't say for certain that that's because of the weak ties, but intuitively, I think that's a logical conclusion, that if you don't have strong social networks to count upon, to lean upon, to rely upon, to support you, then each event that causes distress and disruption is likely to have a greater impact on you than somebody who doesn't. I think that's a generalizable idea within the social capital field.
Also, in the academic field, if someone has a very influential, like a lot of influences with their doctoral student, they are accumulating the citation index overall by citing each other. That's the strong tie among those kind of the academic circle, inner circle. So however, even though someone published a very valuable paper, someone does not have a high levels of social capital, strong social capital in the academic network, it takes a longer time to get the citation.
Yeah, and there is what is it? It's not citation. There's a factor that's impact factor, I think.
Impact, yeah, that's right.
Impact factor that a lot of academics, and you're right, when they're in groups, when they publish paper, they will make sure that they cite each other's latest work. Whether it's even loosely correlated to what their topic is or not, they'll make sure that they'll cite each other's work to increase their impact factor, which is like any other industry. Academia has its standards in that. So what I'm going to do is offer one last chance for anyone who would like to ask a question. If not, I'll give you 30 seconds while I preamble here. The International Social Capital Association has and the link is in the chat, has a Mighty Networks platform, which is a free to sign up platform. It's an online platform where we discuss and interact. We have the special interest group that I'm a chair of, which is disaster resilience, is in there as well. There is a couple of different opportunities in there to join different groups. That is free of charge. The association itself has a nominal annual fee that we encourage people to join. Obviously, the association does need some paid membership to be successful. There are tiers, so depending on where you are in the world, there's a different tiered access, so it'll be far cheaper for somebody in a developing country. And I do believe one last question there. Missed the introductions. That's perfectly fine. Do either of you have sociology degrees? I do not. My education is in public policy and disaster and emergency management. But I believe, Dr. Hwang, do you have a sociology background?
Yeah, I did public administration for my bachelor's and the MPA, but my PhD degree is in sociology. I focused on the organization theory and the social movement theory, testing in the nonprofit and the community resilience and the public sectors. Yeah.
There you go.
Thank
We
you.
love sociology.
Yeah.
Okay, with that, I'm going to thank Dr. Hwang for joining us today and this wonderful presentation on behalf of the members of ISCA, all those watching live, those on YouTube, and for all of those who are watching this at a later date. Feel free to follow us online and take care.
Thank you
Thank
so
you.
much for the invitation. Yeah, have a
Thank
great
you,
day.
Dr. Wang, and thank you.
Thank you.